sunny outside, but there is still some hope that this weekend is supposed to be sunny and warm, so there's some good news there. But I know, a lot of us kind of have been feeling the aches and pains of sitting at our desk at home, a non-ergonomic setup perhaps, and really starting to feel their back pain either return for those of you who have had episodes before, or have a new onset of back pain that you're not really sure how to navigate right now, given that, anything that's non-emergency is really being rooted to alternate forms of care like virtual platforms. So we wanted to put together a webinar for you today just to give you guys a better understanding of what to do about your back pain, how we sort of navigate the various types of back pain, and we're going to hopefully try to simplify it for you guys so you understand, the various tools that are required for us as practitioners, as well as for you as patients, to really help you guys get through it. So it would not be an integral webinar if there wasn't a few of us on this panel. So today, obviously, I'm the moderator, but I'm always a moderator, but I'm also going to be one of the presenters today. So for those of you who don't know me, my name is Dr. Sapna. I'm one of the chiropractors here at Integra. I'm also a registered acupuncturist, and I'm also one of the co-founders. So that's me. I also have Amanda Lee, who is one of our physiotherapists. Hi, Amanda.
Hello.
Oh, we can't see your head, Amanda.
Uh-oh.
We only see your neck. Tilt your screen up.
Oh,
there you go. Perfect. So Amanda's one of our physiotherapists, and she's always excited to educate you guys on all things injury related. So me and her wanted to tag team together. So thank you, Amanda, for doing this with me. I'm super excited.
No problem.
And of course, we also have one of our family doctors, Dr. Amy Polsamello, who is also going to be, hi, Dr. Amy, how are you?
Good.
So Dr. Amy will be here to answer some of the more serious things that come up with back pain. I know for most of us, and statistically, most back pain injuries or episodes are, for the most part, something we call mechanical, which means it's really coming from the structures of your spine, so like, muscle and whatnot, which Amanda's going to jump into in a second. But there are sometimes a lot of things that, we shouldn't take lightly, and that's where, Amanda and I rely a lot on when we need to refer out, or vice versa. When Dr. Amy gets something that's really not that serious, she refers over to us to treat. So, there is a lot of collaboration that happens when it comes time to back injuries and rehabilitation, and just overall helping our patients manage their injuries. So Dr. Amy is going to be able to provide us with that, as well as just helping us kind of understand when should you be getting an image, what's serious, what's not serious. So we're super excited to talk about all of this today, and we're going to jump right into it. So Amanda, take it away.
All right, so first, we're just going to be talking about some of the different types and causes of back pain. Again, we could spend a whole webinar talking about, the cause of your back pain. So really just breaking that down very quickly. And then Sapna is going to get into how we can assess this and a very quick screening tool that we're able to do. And then 5 different ways that you can manage this. A lot of these that you can manage at home. And then Dr. Amy is going to be getting into, when it's important to refer, when it's important to go see your doctor, and the ways that they can help. So jumping into causes, I broke it down into acute and chronic. So acute is going to be what most of us experience. You get the complaint that, oh, I woke up and my back was really hurting, or like I bent down and I got a sharp pain. And a lot of the time we see that sort of gets better day by day, maybe a week or two, and then you're sort of back to living your life like it never happened. It doesn't really affect anything else moving forward. Whereas chronic, on the other hand, we look at more than 12 weeks, so back pain for greater than 3 months. You may have gotten treatment for it. You may have been sort of doing everything that your physio or your chiro, your doctor told you to do, but it's still there. It's still not getting better. And we see that with 20% of our population. So getting into some of the causes very quickly. So we have our structural causes. So there may actually be something going on at the spine level. So our scoliosis, lordosis, so that curve in the low back, our kyphosis, a big curve in the upper back. Are common injuries of sprains and strains, so those bending types of injuries or those twisting types of injuries. Then when we get into our sort of more degenerative things that happen with aging, just these natural changes that happen with the spine. Sometimes there's people who have these changes and then they may have these injuries. Other people, these changes also happen, but there's no pain. So just that degeneration on its own isn't enough to be the source and cause of your back pain, but it does play a role in some people. We have our, our typical disc herniations, our disc bulges, more serious things like cauda equina, and then other areas of the body like the kidneys that can refer pain to the low back. And, pregnancy is often associated with back pain. So different things there that can cause your low back pain. Some of the risk factors for, those more acute episodes, we look at people whose jobs require them to either sit all day or stand and be on their feet all day. People whose just lifestyle in general is very sedentary, not a lot of exercise, not a lot of physical activity. Jobs that require you to do a lot of bending and lifting. And then more lifestyle factors like smoking, obesity, things like that. And so those can be risk factors for your chronic back pain as well, or sort of that acute on chronic. But what we're looking for, or what we see when we're dealing with chronic low back pain, is there's a lot of psychosocial factors that go into it. So what that means is your mood, your stress, what's going on at home, what's going on at work, all of those things are going to have such an impact on whether the acute pain that you're experiencing becomes something more chronic.
Awesome. And I think just before I even get into sort of what we do in an assessment and what sort of things we look for, just to even give you guys like an impact of like how prevalent back pain is, it is the second most common reason people visit a doctor, or call the doctor in this case right now, because of COVID. But it's also, it's something that affects over, I can't remember the exact number, but, I think the statistic was over 78% of Ontarians alone will experience some sort of episodic back pain that requires them to use an over-the-counter prescription in a year. So those are all pretty significant numbers. And so really what this is telling us is that no one's immune to back pain, nor should anyone be scared of it, because again, a lot of it is mechanical and it is quite well managed. And the research also shows us that if we manage it right the first time and rehabilitate an episode of back pain adequately the first time, you're in a pretty good sort of boat of it not really having to necessarily come back. But when not rehabilitated adequately, the chance of it returning in science, like in evidence, is 99%. So there's a 99% chance that your back pain will return if you do nothing about it and you don't rehabilitate it. And a lot of the issues that we come into with why so many people have recurring issues of back pain or have these episodes that kind of keep coming and they don't really know why. And a lot of it is really just getting misinformation the first time around, maybe just relying on only their pain as being acute. And for a lot of us, that is really normal, because when you're in pain, you're thinking about it and you're like, oh my God, I need to get help. But when the pain goes away, because it is a signal, a lot of us kind of just assume that we've healed or recovered, when in reality, there could be a lot of functional changes, a lot of things that have happened to the way we, cope with our pain. So meaning we might start, using muscles differently. We might be weight bearing differently. So again, that's really a lot of the indicators of why back pain for so many people keep coming back, or just returning back to poor lifestyle habits and whatnot. So for us, what's really cool is, we really like to kind of go into a thorough assessment. And for us, we can pretty much already determine what kind of back pain you have, almost just from talking to you. So a lot of the times we rely on a lot of the history findings. And in that, we're listening. We're listening to some of the things that you're saying. If we're worried about, if you're telling us that you're having certain things that you're feeling at night, for example, if you're like, I'm having a lot of back pain and I'm also sweating a lot at night, that's going to make us probe and ask different questions in a slightly different way so that we can get more information. And then once we've completed a good history, we've already started to figure out what sort of pattern you fit into. So I'm going to go into patterns in just a second, which I think is really cool. But, and these are patterns we're going to share with you, so you can almost start to sort of act smart with the person that you're living with later and be like, I attended this webinar and I have, this type of dominant back pain. So it's pretty cool. So we do break it out into a physical exam, and the physical exam itself, again, is just a way for us to really determine, for example, if it is just a muscular problem, is it a joint problem, is it a disc problem, and is the nerve affected? And if it is, to what extent is that damage in the nerve, what extent is that nerve being damaged? And, what do we need to do to get some of that pain or pressure or whatnot off of that disc or that that joint to give you guys relief and to rehabilitate it appropriately. So we'll go into the next slide. So jumping into the next slide, right off the bat, for most people, Jocelyn, you can be my pointer if you don't mind. So for most people, we kind of just start off with, where is your pain and where is the pain the worst? So if someone comes in with saying that their leg is killing them, that's something that we're going to really focus in on, and that's going to put you in a category right off the bat, separately from someone who's saying that their back is killing them. And this is really important because a lot of times we hear things like sciatica. I know a lot of you attended Amanda's webinar last week on sciatica. That's where you get pain in your leg or your buttock. So it's really important for us to know, is it back, buttock dominant, or is your pain leg dominant? And a really interesting sort of like backstory, earlier this week, I actually had a patient who had horrible leg pain, horrible, to the point where he couldn't really walk. We were really worried, and the doctors at Integra did a full workup on him, even sent him for ultrasound, and everything came back normal. And he was deemed an emergent case, so we actually saw him in clinic, and it turned out that he actually had leg dominant back pain. He just couldn't figure that out because he couldn't feel his back pain when his leg was searing to the point where he couldn't even think about anything else. So that it's really important that we know the difference. And then we kind of go into, is your pain always there, or is it coming and going? And then we keep breaking it down further. And so one of the big things that we like to assess for our patients is if your pain is worse going into flexion, so bending forward, or is it worse when you go backwards? And that's where we can essentially kind of break most people who have mechanical back pain into pattern 1, 2, 3, or 4. And honestly, I would say, especially in my practice, like I've been practicing for, I'm going to age myself, but almost 14 years. I literally can tell you I have had probably 99% of my patients fall into one of those 4 patterns. The times where they don't fall into those patterns is, again, where we talk about non-mechanical sources of pain, which is something that Amy's going to talk about. And when we can't figure out what pattern you're in, that's where we're going to, again, really try to figure out, do we need to send you for imaging? Do we need to send you for referral? Because there could be then things that we're going to be thinking about that maybe isn't mechanical. Maybe there's, like a tumor possibility. Maybe there's a fracture possibility. Maybe there's a possibility of something else. So again, that's really where we use our exam findings to really kind of narrow those things down. And then we go into things like, again, what Amanda talked about, are there any other psychological, we call it psychological, but really, how's your life? Are you being affected by your job? Is your stressors at home really putting an impact on your pain? Are you having the right support systems in place to support you? So there's a lot of factors that go into us really feeling, how can we support you better so that we can help you out of this pain? And the strategies around how we help you will differ based on how you sort of fare in your exam. And then lastly, again, we're really looking at red flags, so things that we're really concerned about, and that's where we're looking for neurological changes. We're looking for any sort of pain levels that aren't explained by the exam. And what's really cool is that, especially these days in the ages of virtual platforms like this, we can actually do a pretty thorough exam in less than 5 minutes when we're talking about the physical exam. And actually, this is something that, thankfully, things that were sort of created by actually doctors here in Toronto through the UHN, they actually created a 3-minute low back exam. And I can tell you, in real clinical practice, it's not going to be exactly 3 minutes, but what the exam is intended to do, and what we sort of take from that, is that we can pretty much get the answers of your back pain so quickly. And it's really important because down the road, when Amanda's giving suggestions and modifications, we want to also know, if your pain is flexion dominant, we're not going to give you exercises that are going to drive your pain into more flexion. Similarly, if your pain is aggravated through extension, we need to be cognizant of what actual structures are aggravated. And so we're not going to be giving you extension dominated exercise programs and whatnot. So going into the next slide, I think I covered most of it on here. So again, just talking about the exam, I won't go into it, but really we're like checking things like your reflexes, your neurological exam. We're looking at muscle strength. We're looking at range of motion. We're looking at so many different things. And just by doing that, we'll be able to figure out, what nerve roots are impacting you, if it is a nerve-related injury affecting the disc or the cord itself. So again, this is just a good tool for us to really figure out where we need to go in terms of determining a care plan. And then from that, if we go on to the next slide, what that really allows us to do is, again, for people who fall into different patterns, you're going to see on this chart here that we can actually help guide you in terms of like what medications are actually going to be valuable for you. What positions of relief can we give you? And what's really great is that even positions of relief to give you relief are feel good. They're also great positions for some of these injuries to actually help heal the injury as well, which is really important. And again, just, we kind of have a lot of like evidence-informed practices about how we rehabilitate these injuries. But what we will definitely focus on are certain exercises right off the get-go, and then really graduating them. And it's really important, and this is where most patients fall short. They wait on their pain to go away, and then they stop doing their exercises, or they only initially received like 3 or 4 stretches. And because their pain went away, they thought they were good. But in reality, we really like to actually graduate our patients to the point where, say, after 6 weeks, they've gotten a full set of exercises that are not only just focusing on stretches per se, because it's not a tight muscle situation most of the time. We're going to be giving you exercises that are going to activate your core, restabilize your pelvis, things that are going to really help give you better ranges of motion, sometimes above and below the back itself, and then really making those changes so that you're set up for success from the very first episode of back pain. So this is kind of how in clinical practice, we like to figure out where your back pain is stemming from. But for most of you, just right now, if you're suffering from back pain, you can kind of just ask yourself, and this is a great way to even just navigate if you should take it more seriously, is ask yourself, first question, do you have more pain going forward or going backwards? And then the second question that I would ask you to ask yourself is, do you feel your pain is always there, or does it come and go? And so for some of you who say it's constant, like I always feel it, but it's worse when I do this, that again, I would ask you, is it intensified when you go into certain ranges of motion? And so again, if your pain is just constant no matter what you do, but it's a low grade pain and it's been there for a really long time, you're someone that falls into chronic low back pain. And again, something that we really want to help you with. And if you're someone who's having an acute injury or you're in a lot of pain today and you're avoiding certain movements for fear of, eliciting more back pain, that's where you really want us to help you figure out what you should be doing so that we can get you out of back pain. So I'm going to jump right into now the next slide, which is, I believe, Amanda, who's going to talk about what we actually do.
All right, so getting into sort of those 5 ways to help your low back pain that we, started talking about. The first one's always education. So just general education and advice. So a lot of the times, people, when they come in to see us, they're very fearful of moving. They're scared of making it worse. They don't want to, they want to sort of lie down in bed all day. That's the only thing that feels good. So it's really, opening up that dialogue and letting them know that it's okay to move. You're not going to make this worse. It's going to be better the more you are able to move around, and, keep doing the things that you enjoy doing. And sort of a bit about the natural history of back pain. So how, it starts off kind of like an ache and then it gets really bad, but then it'll start to get better. So just sort of being, reassuring the patient that it's going to get better. Behavioral education. So when you are experiencing back pain for, however long that it does last, you don't want to just jump right back into doing what you were doing, in the same way that you can't just do what you normally do while you're experiencing back pain. So it's really working on strategies that gradually get you back to what you're doing instead of just stopping them altogether. And then more of the physiology of pain. This is something that we really incorporate more with our chronic pain cases, because we know that, at that 12-week point, we expect all those structures, if it's a sprain, if it's a strain, any inflammation, we expect all of that to be gone, sort of healed, but you're still experiencing pain. So it's really educating you on the role that the brain plays in our pain experience, and then getting back into all those other factors like stress, your emotion, on your environment, and all the impact that those have on your pain. So a lot of education in the beginning about what's going on, before, we even get into like the manual stuff or the exercise. So then getting into exercise, I know a lot of the videos I've done in the past have been actually going over exercises. So that'll be something we'll be doing in the future. But today we're just going to talk about it. So a lot of the times if we're doing rehab for a knee or for a hip, it's very, heavily focused on just doing rehab and exercises for that knee, or just doing rehab and exercises for that hip. With the low back, it's very different, because we have so many different body parts that attach to the low back, so many different reasons that could have been causing your low back. So it's a really, really big, comprehensive treatment plan for you. So pretty much everything on this list here is stuff that's focused in our treatment plan. And so it's a big thing that I see is, as soon as people, like Sapna said, as soon as people start to feel a little bit better, they either say, they don't need to come to physio anymore, or they stop coming. But really, there's so many aspects of your treatment plan that we need to address to prevent it from happening again. Because if we don't strengthen your core, if we don't, work on these muscles, then the chances of it happening again are very high. So I always, start off with some core exercises. Usually people tolerate those very well. Like the Mackenzie exercises. So that's a lot of that flexion or extension pattern stuff that Sapna talked about. And it's really trying to get the pain to go, from the leg to move up the thigh to really just try and centralize that into one area. And again, sort of do our assessment to figure out what pattern you're going to fit into. And then, one of the last things we do is really focus on the low back and strengthening that area there. Our hips, our hamstrings, all of those, if those are tight, not mobile, then it's all just going to cause a lot more work for our back to do. So it's really, we really have to assess everything from head to toe and, give you an exercise program that's going to hit all of these things. So getting into some more passive treatments, always active for me is always going to be the first line. I always want, my patients to do as much as they can on, on their own. Without me having to do everything. So there are a lot of cases where there's things that are going to help you along the way, things that are going to make your pain more tolerable. So heat or ice, a lot of people prefer to use heat on their low back. They just think that it feels nice. So totally fine to use those for managing your pain. A lot of more people are starting to get like TENS or like ISC little units at home, those little electrodes that sort of buzz. And again, that's great for pain. It'll sort of interrupt that pain signal to your brain. So it'll help with the pain, but not going to necessarily, fix the actual problem. So if you want to sort of supplement that in with your routine, that's totally fine. Ultrasound, just another modality that we use in clinic for more deeper heating of the structures. Acupuncture, probably has the most evidence for all of these modalities in terms of really the acupuncture that Sapna uses and that I'm currently trying to complete throughout all of this, waiting for our schools to open back up. But we're actually trying to target, the brain, the spinal cord, and that nervous system with that type of acupuncture. So really, really good benefits for acute and chronic pain in the low back. And then Sapna's specialty of spinal manipulation. So if, there is some structural stuff going on, really able to relieve it that way, take pressure off some of those discs if, that's your source of pain, a ton of benefits that way. And then more of the soft tissue active release stuff. So if your tight muscles, if all those types of things are contributing to your back pain, a lot of stuff that we're able to do in clinic. And then, even now virtually, that soft tissue stuff is stuff that we can really teach you to do at home with, either your partner or with, tools that you have at home. So then getting into modifications. So, a lot of people when they come into clinic or when they're talking about their low back pain, they're telling you all the things that they can't do. And people always ask you, okay, can I not, go to the gym anymore? Can I not play this sport anymore? Can I not do this and that? And, I absolutely hate telling people no. And I hate telling people to stop doing the things that they enjoy. So I really work on ways to modify what you're doing. So some of the big things that we see that people have a tough time doing with low back pain are bending over, picking things up, and then probably the biggest one would be like rolling over in bed. It becomes such a hard task if you're really, really in a lot of pain. So just some of the strategies in terms of bending over, teaching people to sort of walk their hands down their thighs if they're trying to bend over, just so you have that support, really keeping your back neutral through that. If you have to pick something up off the ground, so getting into more of a reverse lunge, using your hands to walk down and hinging that way takes a couple more steps, but you're still able to do it with a little bit less pain. And then rolling over in bed. So instead of just like flipping your hips over and then leaving your shoulders on one side, it really, helps if you bring your shoulder and bring your hip together as one unit. So you're not adding that twist in your back. So pretty simple strategies that we're able to go over to help you sort of move around a little bit more normally. And then in terms of actual exercise modification, so, people who work out, people who exercise, their, chances of getting back pain are still pretty high. Like so many people experience it even though they are active. So it's hard to tell someone, who goes to the gym every day that, you're just going to do arms until this gets better. So it's really just making these modifications that are going to provide more support so that you're able to keep doing those. So with the squats, I see that If you're having pain during a back squat, it's easier to sort of do a lunge or a split squat. You know, deadlifts, I think deadlifts have this big like misconception that they're bad for you. And I think if you're doing them properly, you know, they're a great exercise, but you know, a modification for deadlifts would be hip thrusts in the meantime. You know, doing a lot of overhead pressing, you have to, you know, really have a strong core, a strong back for that. So anything that you can do to add more stability, keeping it, you know, your one arm braced down, doing a row, things like that. So again, something that is part of our job is to really help you to keep doing the things that you're doing while you are, you know, experiencing this, instead of just stopping them altogether.
Alrighty, Dr. Amy, you've been quiet this whole time, but this whole slide is yours.
You guys are doing such a great job. So as you guys have already mentioned, you know, a lot of times back pain, if we do intervene pretty quickly right away and correct the underlying issue, then, you know, we don't need to necessarily progress to imaging or necessarily need referrals. I'm going to first kind of focus on the red flags just at the bottom left on the screen, and then we'll kind of touch on medication. So when do we as physicians or allied health professionals get concerned? So the first thing there says neurologic deficits. So if you have new signs or symptoms of something called cauda equina syndrome, which is kind of the red flag, biggest thing we worry about when it comes to low back pain, then we definitely want you to either call or just seek emergency care, whether it be just presenting to an ER. And now what cauda equina is at the end of your spinal cord, the spinal nerve roots actually extend beyond kind of any layer of protection, and they're pretty well exposed. And they actually coalesce together into, you know, if you Google an image, it looks like a horse's tail, which, so that's what cauda equina means. Now, if there is any damage or compression, pressure on those nerve roots, we see things like urinary retention, fecal incontinence, progressive motor weakness, so a lot of weakness in the lower extremities. We get something called saddle anesthesia, which is numbness and tingling in kind of the perianal region. And so those are all major red flags for us. And actually at that point, an urgent MRI would be indicated and a neurosurgical consultation. The second time we get concerned would be if you have a history of cancer, whether it be, you know, active or in remission. Bone is one of the most common sites of a cancer to metastasize. So we do worry about something called lytic lesions, where the cancer can actually eat away at part of the vertebral body. You can get epidural spinal cord compression, again, similar to the cauda equina, but where the cancer is actually causing pressure on those nerve roots. And so at this point, again, urgent imaging would be indicated and probably a consultation with your oncologist. If you have low back pain, it's acute, less than 4 weeks, and you have a fever or night sweats, again, a time that we get concerned. Reason being, we worry about either a discitis, where there's an inflammation of the intervertebral discs, or osteomyelitis, where there's either an infection that has been elsewhere in your body and it has spread through the bloodstream and has now started seeding into the spinal cord. And last few things, if you have any history of osteoporosis or history of long-term chronic steroid use, we worry about vertebral compression fractures. So I've seen it where, you know, we have elderly women, bones are a little bit weaker just by nature of them being postmenopausal. They have either they've stepped off a curb and that pressure or impact has actually caused a little bit of a compression fracture. So if we're seeing pinpoint tenderness on exam, pain that's not getting better after that 6-week mark, we want to get something like even just a plain film lumbar x-ray. Last thing we think about is if you are, you know, relatively young, so under the age of 45, back pain that's lasting longer than 3 months comes with other joint pain, other joint swelling, other signs of inflammation. We think about things like autoimmune diseases, so ankylosing spondylitis, rheumatoid arthritis, and things like that. So we would probably get some initial blood work and then also some imaging looking for any sort of changes there. Now, just focusing more on the medication aspect. But sometimes we need a little bit of pharmacologic assistance. So let's focus first. So over-the-counter pain relievers, I tend to separate these into anti-inflammatories, so non-steroidal anti-inflammatories, or acetaminophen and Tylenol. So looking at the NSAIDs, your over-the-counter options, Advil, Aleve, Motrin, all really good kind of first-line therapies. Always check with your physician. You can call us and double check, make sure that you don't have any contraindications for this type of medication. And that oftentimes is enough. If you take it consistently throughout the day for a couple of days, that can really kind of take the edge off that acute pain. You can alternate it with Tylenol, again, as long as you don't have any contraindications, the major one being kind of any sort of liver disease. You can alternate it because the two drugs work a little bit differently on the pathways of pain, and they're metabolized by your body differently. Next option would be any form of muscle relaxant if you have an issue of coexisting muscle spasm. Plenty of options. Most will be prescription. However, there are over-the-counter options. I tend to be a little bit cautious with these. They do cause quite a bit of drowsiness, so definitely want to avoid driving or operating heavy machinery if you're taking these. I tend to have people start them at night just to see kind of how you respond, if it's even going to work for you, and then at least it'll help you sleep as well. Corticosteroids, the evidence for this isn't really great. I see it prescribed a lot in the emergency room setting, mostly for kind of a 5 or 7 day course. We call it a steroid burst to just really decrease that inflammation in that acute stage of the pain. Topical analgesics are a great option. Topical anti-inflammatories, even better. And then really last resort for refractory or severe pain, opioids, again, very short-term course because of the risk of dependence and the potential for side effects. So again, if your back pain is just not responding to anything else, we tend to use this, or in cancer patients, people who are awaiting surgery, it's a reasonable option, and even kind of immediate post-op. And last, if there is kind of that coexisting depression or mood component, which often comes with the more chronic back pain, antidepressants are actually, there's pretty good evidence for them in treating chronic pain and then also depression. So things like Effexor or venlafaxine, duloxetine or Cymbalta. Sometimes we use gabapentin or pregabalin. We borrow from other kind of categories of medications. So those are actually anticonvulsants, and then tricyclic antidepressants as well. Please, again, always check with your physician or call one of us to kind of get some advice on this.
Awesome. Dr. Amy, that was so thorough. Thank you so much. And that's the thing too, like we even hear it in our own practice. Like I had a patient not too long ago, a chronic pain patient who, was taking over 3 muscle relaxants a day, the max dose of Advil, the max dose of Tylenol, and those are things that we obviously want to kind of evaluate and have a doctor on it because, like they're asking me, that's fine, right? I'm like, no, I don't know your medical history. That is not appropriate for me to even counsel you on. And it's also something that I'm concerned about because if the coping of that pain is that significant and the medications are not alleviating your pain and you're taking the max or even over max dose of that prescription or over-the-counter medication, we want you to talk to your doctor and just get some proper counsel on that because it's super, super important. And I think just also a quick thing too for Amanda and I, we're fine for you to take medication. I think there's a huge conception that like, oh, well, I shouldn't take pain meds now that I've started treatment. We want you to take the pain meds so that you can tolerate treatment. Like we don't put you through an easy course of anything. Like we kick your butt so that you get better faster. And so if you're literally in a position where you're afraid to take the medication because you want to be able to tell if you're getting better from treatment versus, the pain meds, there's no correlation. We'll know over a couple of days what your progress is. And I think it's really important that we all realize that we encourage it. We want you to be like not suffering while you get this therapy. So one person actually messaged me directly, and this is, I'm going to just start with the first question, and then we have a couple that we're going to break down that are really good for all of you to hear. So please stay focused. We're going to try to answer these quickly. So the first question was, when should I start getting treatment for a low back injury? This is really, really important. And I know I'm going to get Dr. Amy to jump on this too. And I think even Amanda will probably agree. If not, she can jump in and add some extra points to this. But what I tell my patients all the time is the faster we get our eyes on it, the faster, and get you treated, the faster you're going to recover, whether it's a severe disc injury or even just, a muscle strain or a joint sprain. We are going to be able to get you rehabilitated quicker. And I think a lot of the times, patients wait thinking, it's going to get better. And then before they know it, they blink, they're busy, and it's been 3 weeks. Don't suffer for 3 weeks. If your injury, I always tell most of my patients that if your pain is persisting for more than 3 days, it's most likely not muscular at this point. If it's persisting for more than a week or two, you're definitely looking at some sort of joint, some sort of neurological or disc-related factor that we need to rule out. And those are already going to be harder and more difficult to treat the longer we wait. And a lot of it can be, resolved within a few appointments. But I always tell my patients that the longer you wait, the longer you're investing in having to get, long drawn, blown out treatment plans to get you better and back to your goals, rather than just coming in, or in this situation, if you aren't urgent, getting, virtual care so that you can actually get your back pain resolved faster and you can take more control over your back pain so that you can get on with your life and live, pain-free. So that was my approach to that. Should we start treatment? So Dr. Amy, do you want to add anything to that?
Yeah, no, I completely agree that kind of the sooner that we are able to see you and assess you, the better that we can kind of recommend a treatment plan that's going to start correcting the problem if there is one, and minimize your pain. So I agree, sooner is better when it comes to back pain.
Awesome. Amanda, anything to add before I go into the next one?
No, same thing.
Okay. Yeah, awesome. Okay, so this is a good one. Okay, so this particular patient, I'm going to let Amanda answer this. So Cindy asked, regarding workout modifications, core workouts always seem to trigger my low back pain. Are there any general core modifications you recommend?
Yes. So like the big thing before we even get into like, your typical planks and your, side planks and like crunches and all those things, before we even get into those with anyone experiencing back pain, we want to make sure that you're engaging your transverse abdominis. So our very, very deep core muscles. And usually those tend to be the exercises that are not painful because you're not doing a ton of moving with the rest of your body. You're really just activating it by these small contractions. So, it's really important that we're teaching you those first and you're learning how to do those properly, because then when you get into doing, the big core exercises, the ones, you see everyone else doing, it's if you're not engaging those small muscles first, then we're not really achieving what we want. So I can show you a ton of different core exercises that shouldn't be painful, that are pretty easy to do at home. If you sort of just shoot me an email, we can sort of set something up and I'll show you that way.
And another thing to jump into for Cindy, like when someone says core workouts, I see this all the time, and I'm going to just zoom in here, where I see people doing a lot of core workouts where there's a lot of this happening or a lot of this happening. And that's definitely also something that, we would really want to know, again, where is your back being triggered? What workouts are actually triggering your back pain? And what's your background? Again, we would want to know a history, because, in this specific situation, we don't know who you are, but, if you were postpartum, maybe you're, under 1 year after having a baby, maybe, there's a previous injury related here. Maybe you have recurring back episodes outside of just working out. So again, these are all detailed questions that we'd want to know before, even Amanda was saying to give you all those exercises. And she's right. Most of these core exercises should not be painful and should be actually helping your injury. But that would definitely be something that I would add as well, because a lot of the times when I see, a lot of clients or patients telling me that they're doing all these core workouts and then they show me and I gasp and I'm like, oh my God. And, part of it is because I used to be a personal trainer for 5 years before I became a chiropractor. But a lot of the times people do these exercises and don't realize you're actually just aggravating your hip flexor muscles, and your hip flexors are a huge part of our back. We didn't talk about that much today, but, when your hip flexors are overworking, that's going to just keep offsetting your core. And it's really hard for some people to not engage their hip flexors when doing core workouts. So that would be something that I would add to that. So definitely, we're definitely at a point where we would say, definitely email, let us get more information about this. And then also, get a proper tailored workout program. And that's one thing too, that like Amanda and I are actually doing for clients. If it's just trying to teach you how to work out, we can actually give you workout programs that you can do very similar to a personal trainer. And that's where sort of some of our virtual rehab services come into play. And if you're urgent, or if you have neurological symptoms, something that your pain is at the point where you can't really tolerate it, We do have urgent in-clinic visits available as well. We're obviously practicing, physical distancing. We have protective equipment as well. So we have, we're taking a lot of very strict protocols to do this. And so we would be screening you to see if it's appropriate or not. It's not something you can just book and come in, but definitely something to consider. But for a lot of back pain recovery, so much of it is active and so much of it is exercise-based. So here's another good question. So you already answered what muscles are involved. Amanda just talked about this. For Glenn, we already talked about the transverse abdominis and some other smaller muscle groups. So we'll say that answer is, or that question's been answered. But moving from, here's another one. This is from Anonymous. Moving from chair to chair in the office or at home requires me to bring my back roll with me to insert at my lower back. But that is a nuisance going everywhere with it. Is there something that can be done? And can I, as a 60-year-old, ever expect to be rid of this companion? Which I think the companion is the back support. Who wants to take a stab? Amanda, you want to go?
Sure. Again, so it's important to, figure out why it is that you need that support. What's not holding you upright? What's not supporting you that you feel that you need to have this in your, supporting your back. And like all these things are, again, like I said, are great tools to use once in a while, if you're going to be sitting, for a long period of time. But at the end of the day, we really want to figure out what the source of your pain is, and then what we can do to create more long-term like body changes that are going to, cause you to not need that pillow. So again, you're a great person that if we can sort of set up an assessment with, really take a look at your posture, take a look at, how your muscles are working, how, what needs improvement in strength, and then really work on, creating a program for you from there. So, I mean, to sort of answer your question, I don't see that like that's something that you need to have for the rest of your life. I would love to help you not need that, not to depend on something. So I think if, you can figure out what's causing your pain and figure out what exercises are going to help, that's not something that you have to, carry around with you everywhere you go.
And even just something to add on that, like just as simple as learn better, we can teach you better ergonomics. I think that's another thing. A lot of the times you might just get set up for your workstation at your office, but no one's really helping you with various chairs and things like that. So again, that's just a lot of stuff too that Amanda and I do to actually help you ensure that when you are going into a new work setup, whether now it's at your home, your dining room, whatever, but back when you go back to the office, to really figure out, are there even just small modifications that you can make so that you're not putting so much pressure on your back? Because a lot of the times, I always say, you can buy a $1,000 chair or a $100 chair. If you're not sitting in it right and your butt's not doing what it's supposed to do, that chair is literally useless. So that would be what I would add to that. So here's another one. So Michelle asks, if it's easy to bend forward and almost relieving, but the pain / tiring to bend back, but there's pain or / fatigue to bend backwards. Can you explain what the more likely cause or root cause of this pain is? Like, what area should I be focusing on strengthening if it is challenging to bend back but not forward? So just on my end, again, for a lot of the times when patients are noticing that they managed to successfully bend forward, but then they're struggling to get back up, we're looking at a couple of things. For sure, we're looking at the posterior chain in general. What are your glutes doing? Are they contributing and assisting at all, in that position? Your abdominal strength and your back conditioning. So on my end, I would definitely say, there is definitely something to look at from the endurance of your core muscles as well as your posterior chain in general, not really working very effectively. It could be a cueing problem. It could be a weakness problem. It could be, just an underlying instability or injury that's just not really, hasn't been effectively rehabilitated. And so the strategy you keep using to get up isn't really effective for you, and that's why you're struggling. Anything that you guys would add to that, Amanda?
Yeah, I mean, in terms of what you should be focusing on strengthening, again, sometimes, it doesn't need to be a strengthening thing. It's getting into that sort of extension exercises that, we were talking about when you have your flexion or extension biases. So just trying to incorporate more extension movements into your day.
Mm-hmm.
I think.
Sorry, go ahead.
One of the classic diagnoses that we see with, pain is better with flexion, worse with extension, is something called spinal stenosis. which some people just congenitally have or born with a narrower spinal column. And so when you do that forward flexion, you're actually opening that up a little bit and relieving some of that pressure. So again, see your chiropractor, see your doctor, and see if that could be what's going on. But I think you guys kind of address the management or treatment of it. Sometimes it does end up being a surgical issue, but kind of last resort.
Totally. Yeah. So Michelle, definitely touch base with us. I think that's a big one. And we would really want to know a little bit more about you. Again, we don't know how old you are, what your situation is, any of that stuff. So that would be very helpful for us. Okay. Amanda, any suggestion for soft tissue release while we're unable to access our massage therapist?
Yeah. So, essentially how soft tissue works is it's just lengthening and shortening the muscle while applying pressure. So, really depending on the area of the body that you need released or that your massage therapist releases, can definitely sort of just show you that, set up a video appointment. Even do an assessment. It may need more than just soft tissue release. Just sort of, we always want to supplement it with exercises with sort of stability stuff. And then, we could really show you how to release them yourself. A lot of the times, all you really need is your hand and applying some pressure, or, a massage ball and something like that. So if we sort of just even set up a call, you could just let me know, what that area of the body is that you want released, and then we can go from there and show you how to manage it at home on your own.
Awesome. Okay. And just really quickly, I know we're running out of time. So like we already mentioned, for those of you who do have, emergent or urgent back pain that is not resolving, so a lot of the times, like if it's persistently getting worse over the coming days or weeks, if you're starting to get that leg dominant symptoms that we talked about, if you're feeling that, no matter what pain medication you're using, or even with assistance, you're really having a hard time getting around, that is something that we would adequately say is appropriate to call us. There might be an availability for us to see you in the clinic if it's appropriate. We might try to manage it with virtual care. First, it really depends on the situation. So definitely give us a call to find out. We're not booking that online. However, if you did want to get some more information, virtual rehab, it's going extremely well. Patients are getting so much success from their care programs. And, we're not kidding. Like Amanda and I really do hold you accountable in our sessions. We do treat it almost like we're your rehab therapist or your rehab trainer is kind of like a personal trainer for injuries. And, it's going really well because we're able to really get you focusing on your fundamentals and your foundations and using this time to really get you safely, healthier so that when you do get back into, your gym workouts and things start to reopen, you're not trying to hit the ground running and then getting even more injured and then needing to be in our office when things kind of are at that point. So we really want to make sure that you're setting yourself up for success right now. And I know there's a lot of great workout programs and things like that, but rather than guessing, use us because we can really help you figure things out pretty quickly and get you results fairly quickly as well. So anything else that you guys need help with, obviously call us. Our doctors are open virtually. We have a lot of support systems in place for you guys. So as always, you know where to reach us or email us. So call us or email us. And until our next webinar, I believe we don't have any upcoming webinars for this week. So nothing to have you stay tuned for, but we will be sending out some announcements next week. And if we didn't get to your question, definitely send us an email or call us or just respond back to that registration link, and we will definitely get that for you organized so that one of us can give you a call to answer it in more detail. And I think that was it. So until next week, Amanda, Dr. Amy, thank you so much. You guys are always awesome. And hopefully to all of you guys, this was helpful, and we'll be in touch soon.
Bye, guys.
Bye, guys.